Hey, welcome everyone to Adapting Hospital at Home to Alternate Settings, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. The Users Group is the nation's premier collaborative focused on acute care at home. The group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website and be sure to check out our TA Center for Helpful Hospital at Home program resources and tools, as well as our recently refreshed Research Center. And you can follow us on Twitter X and actually soon on LinkedIn. This is our 34th webinar, so you can view any of the 33 previous user group webinars, a few of which are described here. Find a topic you have been thinking about or working on, and please take a look. Some news from the Hospital at Home Users Group. Registration is now open for Leveling Up, Investing in Hospital at Home and the Future of Healthcare, in this year's virtual Hospital at Home Users Group annual meeting scheduled for October 16. Our programming includes an up-to-the-minute policy update, provocative keynote, networking opportunities, presentations of cutting-edge research, awards showcasing the best of the Hospital at Home community, and much more. Leveling Up will also feature exciting work from members like you. So to that end, we are calling for submissions of poster abstracts, award nominations, and photos and videos. You can visit our website to learn more and send in your submissions by July 1st. And you can use the QR code to get to the site there. And as in years past, the Users Group annual meeting will be a pre-conference for the in-person American Academy of Home Care Medicine's annual meeting on October 17th and 18th in New Orleans. We hope to see you virtually and or in person. We did want to send a call out to all active hospital at home programs to help us advance the field of hospital at home by participating in our Minimum Data Set Initiative. Developed by the Users Group Quality Indicators Council, the MDS is a de-identified patient-level data set that seeks to capture information on all patients enrolled in hospital at home programs nationwide. There's no cost to participate. We hope you will join the 33 hospitals that are already involved in this essential work. Again, you can scan this QR code and fill out a short interest survey, and the Users Group team will be in touch. It's now my pleasure to introduce our moderator for today's webinar, Taki Michaelides. Dr. Michaelides is an internal medicine physician by clinical training and practices as a virtual home hospitalist in the UMass Memorial Health Hospital at Home program, where he is a medical director and faculty in the program in digital medicine at the University of Massachusetts Medical School. Prior to joining UMMH, he was a senior medical director in the Atrius Health Home Hospital program. There, he supported local and national hospital at home development and developed and scaled new acute and post-acute home-based care models for the predominantly frail, medically complex, and homebound population in Eastern Massachusetts. Please take it away, Dr. Michaelides.
Awesome. John, thank you so much for the kind introduction to the Hospital Home Users Group and the Users Group leadership team. We're in a really important moment in home hospital in the country. We've been practicing under a CMS waiver for the last 5 years or so, and we have a waiver extension coming up at the end of September that we need to be working towards. We have bipartisan support for hospital home, and there's a real desire for interventions across the country that increase access, that improve health equity, and also importantly, that work in urban, suburban, and rural environments. And hospital home, I think, can really help here with intentionality in particular around the design of the home hospital program for alternative home environments. This is a critical issue. We're very fortunate today to have 3 excellent panelists joining us to talk about how we can adapt hospital home to alternative settings. So without further ado, I'd love to introduce our 3 panelists. Perfect. So first of all, Rachel Mears has 20 years of collective management and clinical experience in the acute care, outpatient, and home care settings. Rachel has been the nurse manager of the VA hospital home program in the Boston area for nearly 5 years, which provides both acute and transitional care to veterans in their homes with the goal of preventing hospitalizations and/or decreasing length of stay. Additionally, she assisted in the development, implementation, and nurse leadership of the VA Choose Home program, which is in its second pilot year. Rachel is passionate about the value of home care and the unique personalized plan of care that is allowed in this setting. She looks forward to expanding both acute and transitional care options and programs into the home at the VA Boston. I would also like to introduce Dr. Fitz Shepard, who is a board-certified internist at Boston Medical Center, right around the corner from my home, and an assistant professor of general internal medicine at Boston University Chobanian, and Avedisian School of Medicine. An experienced hospitalist with a focus on patient-centered, high-value care, Dr. Shepard took on the role of medical director of BMC's new hospital home program in January of 2024. He received his medical degree at the University of West Indies Faculty of Medical Sciences in Jamaica and has been practicing for more than 14 years. And last but certainly not least, I'd like to introduce Dr. Michael Nassif, who is the medical director of St. Luke's Hospital in Your Home program. He is a board-certified cardiologist within St. Luke's Cardiovascular Consultants and is on staff at St. Luke's Mid-America Heart Institute in Kansas City, Missouri. Dr. Nassif received his medical degree in 2009 from the University of Iowa, completed his residency, chief residency, cardiology, and heart transplant fellowships at Barnes-Jewish Hospital, Washington University School of Medicine. During his training, he also completed a cardiovascular outcomes research fellowship and master's degree in clinical investigation at St. Luke's Mid-America Heart Institute, University of Missouri, Kansas City. Dr. Nassif's research interests focus on the intersection between diabetes and cardiovascular disease, with a specific focus on heart failure. We have asked our three panelists to share just a really brief 5-minute high-level introduction of their program with a key focus on how they may think about adapting hospital home to alternate settings, including group homes, medical respite facilities, and ALFs or assisted living facilities and independent living facilities. Our plan is to have a brief Q&A amongst the four of us and then open up to the floor for the last 20 minutes or so. So without further ado, Rachel, let me turn it over to you to kick us off.
Thank you so much for the introduction. I'm really happy to be here with you all today. I'm going to go over a couple of unique settings we go to at the VA in Boston. Just a little background, we enrolled our first patient in May of 2019 prior to the CMS waiver. We've continued to grow every year since, with over 200 unique patients enrolled in fiscal year 2024. Patients typically go through an acute phase, which lasts about 7 to 10 days, followed by a post-acute phase where we taper visits down to ensure stability on new medication regimens. With that longer taper, our length of stay tends to be about 4 to 6 weeks. And since we are VA, we don't have to follow any CMS regulations for visit frequency or duration. We enroll patients that reside in all the usual places. For example, a typical home, assisted living, shelters, or hotels. The two that are probably unique to the VA are CRC homes and rest homes. CRC home is a privately owned residence or group living facility in the community that is approved by the VA to accept placements. Each home has a facility owner or sponsor who assumes the responsibility of managing the home. This may be the person providing the direct care, or others may be designated as the managers or staff members. CRC homes were originally designed for veterans with serious mental illness. These provide supervised housing and health care to veterans in the community who are unable to live independently due to medical, psychiatric, or psychosocial limitations. Generally, this setting provides minimal supports and hands-off care. Typically, there are no curfews. Residents can come and go as they please. They may have cars on site, and the veterans are overall functionally independent. Residents get a bedroom, meals, and laundry, and a staff member is on site 24/7 and can help with medication prompting and care coordination. Rest homes are long-term care facilities. They're licensed by the state and regulated by the Department of Public Health. There's currently 74 operating in Massachusetts. There's 58 freestanding and 16 SNFs that have rest home beds. While nursing homes provide skilled nursing care and medical monitoring, rest homes focus on supportive care and supervision for those who don't need that level of medical intervention. Rest homes are supervised by RNs. They have activities directors and also have CNAs to support ADLs. Medication management and administration are typically provided. However, skilled nursing care is not. So our process for enrollment in these settings still includes a referral, chart review, and in-person assessment of the patient. It goes a step further with having a conversation with the people in charge at the home or facility. Medication management varies depending on the facility. At the CRC homes, they typically don't do too much with the medication, so we can manage the patient like we normally would if they were in their own home, for example, like setting up a med planner. At the rest homes, RNs typically administer medications, so we usually have to fax orders over anytime we dose adjust, start something new, or discontinue medications. And this can be a little more challenging, and sometimes the orders aren't followed through on in a timely fashion. In our early stages of the program, the idea of our care was met with some reservations, but now that we've been to most of the common places in the area, the staff know us. We've received a lot of positive feedback and are pretty welcome most places. It is interesting to mention, though, there's a facility that houses nearly 500 veterans in both long-term care and domiciliary beds. It's called the Chelsea Soldiers Home. And we're not allowed to go there due to their directives, which state that residents can't be treated for acute medical problems while they're there. And this highlights some of the places that we've started to provide care to veterans who don't live independently at home.
Fantastic. Thank you so much, Rachel. And there's so much richness there. Looking forward to getting into in the Q&A. Moving on, I'd like to introduce Dr. Fitz Shepard. Fitz, to you.
Thank you. Thank you. So I'm Fitzgerald Shepard, Medical Director for Boston Medical Center Hospital at Home. So we launched in April of 2024, and our main site, Boston Medical Center, is where all our patients are coming from currently. It's a 500+ bed hospital. Our hospital at home unit currently has a cap of 12 with an ADC of 8. As you see, our case mix index is very similar to the case mix index of the brick and mortar BMC hospital, with a reduced readmission rate in our hospital at home unit and demographics that mirror our brick and mortar unit. And a part of the mission of BMC is a very strong focus on health equity, increasing access to care for all our patients, and with about a 70% Medicaid population with a significant at-risk population, we thought it prudent to ensure that we are not limiting our hospital at home services only to those who are stably housed. We were also considering patients who had some element of housing instability. So in this case, transitional housing, which is somewhat temporary housing for patients who are otherwise homeless or experiencing housing instability, to help them transition to permanent housing. In this particular case, we had a patient who was in a transitional housing setting at the YMCA, did have some history of substance use, and came in with alcoholic cirrhosis with ascites. We were able to successfully care for him in our hospital at home unit. He was admitted during the summer of last year. We were also able to see his structure in his living facility and saw where there were areas that we could even improve it. We were able to provide a fan, and as simple as a power strip to plug the equipment in that we were providing was very useful, beneficial to him, and appreciated. From a medical perspective, he was able to get the same level of care that he would have otherwise received in a brick and mortar unit. And the impact to him, I think he greatly appreciated being in his area of comfort, even though he was experiencing housing instability. And he was around persons that he knew, and we were able to provide that care in a way that was respectful to him, allowed for his autonomy, and respected his dignity. In so reinforcing our commitment to health equity and access, even in a transitional housing situation. And in this case highlights that of a young female who had 3 children who accompanied her when she went to the ED for a complex mastitis. What we're saying here is even patients who are in a shelter, and the shelter here is the women and children's shelter, where they have their own room. So for example, she would have her own room in a complex that has shared living quarters, shared restroom, shared kitchen. But in terms of her living quarters with the bedroom, that was her and a cot for her kids. And we were able to set up our hospital at home services in that setting because alternatively, because she was needing to be admitted and she had nowhere for her kids to go, were it not for our hospital at home unit, it would actually require DCF to get involved, and she may then have been separated from her kids. So we were able to ensure that we maintained the family unit, maintained that stability during her hospitalization, while still delivering that high quality, equitable care. She was able to get her antibiotics as recommended by ID Consult. She was able to get her lactation education by virtual lactation consult. And we were able to show how we are able to deliver that same high level care in non-traditional settings. So just want to, highlight that there are key adaptations that would need to be in place as we think through these alternative home settings. The assessment of the space to ensure that there is some level of privacy. So in the case of the women and children's shelter, she had her own bedroom. We are respecting patient autonomy, patient safety, in that we are also speaking to the persons who are managing the shelter or managing the transitional housing facility to let them know that persons will be coming, medics, couriers, etc. Flexible setup, on-site partnerships, and be sensitive to our care team, both the team going in the home and the team virtually. And I'll pause here and pass over to our next presenter as I'll get through the details on the right side when we go through our Q&As.
Fantastic. Thank you so much, Fitz. Such a powerful story of keeping the family intact, to say the least. And there's a lot of richness here to go a little deeper in, for sure. So thank you, Fitz.
Thank you.
Michael, let me turn over to you.
Thank you so much. It's always a very exciting group to chat with and speak with, and a lot of leaders, luminaries on here who've done me a lot of favors. And I think Taki's changed his number from all the times I've texted him to ask him for some quick curbside advice. So always pleased, and thank you for having me. And they'd asked me to discuss, and it was kind of perfect. I said we've had some home runs with some assisted living facilities, and also had quite a few strikeouts. So happy to share my experience on both sides of that. I've no financial conflict of interest, though. I don't know if it's a spiritual conflict of interest, but I do. I'm a heart failure cardiologist by background, which if you do enough inpatient and post-hospital follow-up cardiology, you become a geriatric cardiologist, which I particularly enjoy, and it really lends itself well to hospital in your home. And I can't describe to you how much better, especially elderly heart failure patients do. My new phrase is that the best place to urinate is at home, and that's what most of my heart failure patients need. And so the hospital in your home blends in a perfect solution there. So I got to tell you, for assisted living facilities, memory care facilities, it makes all the sense in the world because, from the assisted living standpoint, if that patient goes to a brick and mortar hospital for 5-6 days, the likelihood of them needing a skilled nursing or something other than assisted living is extremely high, probably 20-25%. So they should be incentivized and aligned to have hospital in their home on their campuses. But likewise, they have a lot of the resources that really make hospital in your home a success. Memory care has people passing the meds. They have somebody to help them if they need to get to the bathroom. And so really, if you provide the hospital in your home, inpatient specialty care should blend itself with the resources quite nicely. And so I'll be honest, when we first, I remember yesterday, I called this assisted living facility and they told me no. I was incredulous about exactly why. And we can go to the next slide. And I'd say that single biggest challenge is the great majority of these assisted living facilities are not locally owned. You know, the majority of them are private equity owned, and just being able to talk to any decision maker is incredibly difficult. And I think there's a little bit of a mindset that saying no is always the safest bet, and saying yes, they think takes on some risk. And so the one that always comes up, like I've talked to the highest level supervisor I can get a hold of, and told them like, oh, this sounds great, and the patient's interested, and the doctor visits virtually, the nurse practitioner will come in person tomorrow, everything's great. And then when they hear there's an IV, a lot of them have a strict no IV policy, and I try to assuage them that we are responsible for the IV. We will troubleshoot the IV. We are here 24 hours a day. But I'd say the two big concerns is one, the IV, and two, they assume there's going to be some extra burden on them by having by definition, sicker inpatient within their facility. And the two things I tried to hammer home is that three things is, one, we are responsible. Two, we are very well staffed, very well resourced. We'll be able to in person 2 to 3 times a day, virtually 5-6 times a day. The other one that I do think they find reassuring is tell them if it is not working out, we just bring them back to the same hospital bed. They don't have to go to the ER, nothing like that. We have a very smooth process to bring them back. So it's not a one-way street. And I'm going to be honest. So that we have two incredibly successful assisted living facilities. The one we kind of marked as a key partner. It's a 2,000 resident assisted living facility right next to our community hospital, St. Luke's East. But I will say we put an immense effort. When we were actually trialing and testing equipment for hospital in your home, with Medically Home, we actually had a resident there be one of our trial patients before we even launched. So we were in the facility. They invited me there to give a presentation at lunch, and it's kind of funny. I was like, "Well, you won't even show up," and the director there was like, "If we say a doctor is coming, he's like, they'll come in droves." And it's true. I felt like Taylor Swift. I've never had such an engaged audience in my life. We've had our nursing director there multiple times. We've done media. Our story was about a resident there. And so we did put a lot of effort. It's incredibly successful. We partnered with them. We're about 2.5 years old. I need an exact number, but I know we're over 40 patients that have just come from the single assisted living facilities, both assisted and memory care. And we have a great relationship with the primary care doctors there to give warm hands-offs. And it's, really for our staff, it's also a small blessing when they go there because we know the system, we know the security guards, we know how to get in, we know the door codes, we know the access codes. It's very, very convenient for all. And so, interestingly, we started with that one. So then maybe I got a false sense of security about how easy that would be. And then, we've had a few failures. So then we started at a different community hospital, our St. Luke's North Hospital, and we kind of asked them for a list of what assisted living facilities you work with frequently, and they gave us one. And I'll say one of my maybe pearls is this was about 150 to 175 resident assisted living, but it's right next to the hospital. But I'm not joking. So I met with their director, and they wanted me to meet with the medical director. So then I met with the medical director, and then they wanted our nursing director to meet with their nursing director, and they wanted our operations director to meet with their operations people who were in Maryland based, I believe. And so we had 4 or 5 meetings in 6+ hours. And we've admitted one patient from that assisted living. And now they've called us a few times, but unfortunately, the things they're calling us were more of maybe an urgent care or an urgent outpatient visit, but definitely didn't, meet kind of criteria for an inpatient hospitalization, which is a significant challenge. We've always told people also to call us and try to involve us early if a resident is coming to the ER or coming to the hospital, but inevitably those patients end up being on operations. So that's one of our failures. And I say the third option that this is what we've adopted. So I don't know the exact number, but I can tell you the other one we've been successful with is about 1,000 residents. So I will tell you if it's like 100 or less assisted living, it's hard to say if that juice would be worth the squeeze. But the one we have this 1,000 been very successful. The John Knox Village is the name. The other one is 2,000 residents has been extremely successful. I think those are no-brainers. And the other one, the policy we've adopted is we just cold call them. Essentially myself, our geriatrician, Jill Huded, our operations director, Amon Baines, if we have a patient that wants to go in from assisted living facility, we call them. And I'd say we have about 50-50 success on whether they'll take them or not. But so, yeah, I would identify, you know, and like I said, especially anything with over 1,000 residents, anything that is in very close proximity to your hospital. And, you know, I do think at that size, that volume, and that proximity, it is worth the maximal effort. But I'd also try, in hindsight, when I reach out to these, if you had a more mid-sized one, I'd reach out if there's interest. I'd try to streamline, like let's bring the nursing director, the operations director, or the medical director, and have one lunch, one sit down, as opposed to these. And the other one is, you know, it was good that we launched with that really large one, John Knox Village, and was successful, and that really helped us when we wanted to launch with the other one that's in our Overland Park, Kansas location. Is we told them, hey, it's been super successful at kind of one of your large competitors in the area. So I think that's very motivating for them to try to partner with you and try to make this a success. And that's all I have talking.
Awesome. Thank you, Michael. I love the start with your larger opportunities and have those conversations. I also love the story of you going all the way to the senior leadership. You know, there's a scrappiness and a passion and caring for the patient there. That's a testament to you and the team, and I think probably reflects a lot of the passion that many of us in Home Hospital have to do the right thing for the patient. So kudos for sure. All right, so I'd love to open a little bit up for discussion. And Fitz, I think these first couple questions would love to turn to you. And maybe taking a step back for the moment, you know, hospital home programs that are being built in health systems such as Boston Medical Center that are serving disadvantaged populations. Can you talk a little bit more about how to think about preparing in advance, designing with intentionality for disadvantaged populations, you know, even months or weeks or maybe even years before you take your first patient?
Yeah, and I think that's a perfect question because it actually speaks specifically to how we see ourselves and how we position ourselves as an institution. Speaking of Boston Medical Center, a big part of our mission is health equity and access to care. We wanted to ensure that our hospital at home unit was mirroring that same mission that our hospital already stood for. So it would seem somewhat different if we were to exclude patients based on them being disadvantaged, especially considering that a large proportion of our population is the at-risk population. So I think even from launch or prior to launch, we were already thinking about how we can ensure that we're allowing everybody to access this care, particularly if we're promoting this as something that is the same quality of care that you're receiving in brick and mortar. Someone coming in through the ED, if this is a acceptable standard of care, quality care, why should I not be able to receive it? If I'm already marginalized out in the community, when I come into the hospital, I should not feel marginalized again. So from the very outset, we said, how can we ensure that we're able to provide these services to all our patients? And I think the first thing we did was to go into the community, to ask the community, you know, is this something you would be interested in? What do you think about this? And we did the market research upfront and got that level of interest from the patients. I think people think, you know, patients who are either unhoused or unstably housed do not want to be where they were coming from prior to admission, but that may actually not be true. If that's their area of comfort, that's where they feel most secure. Many patients actually do want to be in their comfort zone, as is what we're promoting in Hospital at Home. So we did community engagement. We actually went out into the community. I actually participated in some of the community engagement efforts. And we set up booths there was a parade, we set up a booth. There was a church gathering, we set up a booth. And I think there were a few other community events that were happening in the surrounding areas. And we set up a booth there. We were informing patients about our upcoming Hospital at Home launch, even before we launched, so that patients were aware of it, so that when we did launch, it's something that they could ask for upfront. And then after that fact, after we launched, we ensured that we went back out to the community to say, this is in place, this is what it is about, this is our Hospital at Home unit.
Thank you, Vince. I love that. I love the community first approach from a needs assessment perspective, and also you sharing benchmarks for us to think about equity. How do we make sure that we're offering the same optionality to all patients? And I think I heard you speak in your presentation around seeing mirroring of demographics in your hospital home program, as well as mirroring of acuity in your hospital home program with brick and mortar. And I think those are things that we should all be aiming for and assuring from a hard data-driven perspective. So great for sure. The other question I'd love to ask you, Fitz, is, Boston Medical Center has had a long experience working with outpatient medical respite facilities and being closely partnered. I understand you're exploring how those medical respite facilities could perhaps be a site of care for inpatient hospital home level care. Can you talk a little bit more about how you think about, kind of green lights versus maybe yellow lights as you think about your criteria for success with a medical respite facility for inpatient hospital home care?
Yeah, perfect question again, because what we're along that same line are thinking, while we are able to now take patients who are unstably housed, so transitional housing, women and children shelter. I mean, we have to clearly state the caveat that when we say shelter here, we're not talking about communal open space shelter. We're saying the patients have a room. So they have 4 walls of their own that allows them some semblance of privacy, so that we can deliver medical care, but still respect their privacy as HIPAA would dictate. Now, as we think through that, there's still a subset of patients that would be missed. And those are the patients that are truly unhoused, meaning they do not have such a shelter or transitional housing space to reside. And we thought, why are we excluding such patients? Is there a way that we could bring them into the fold and still allow us to offer that same level of care? So as we think through and work with our respite partners, what we're looking at in terms of like green light is there an area that allows for privacy? Is there an area that allows for med management? Because within our hospital at home structure, and we're still trying to mirror the structure that we're delivering in every other patient's home, we don't want to have 2 separate workflows, right? We don't want to have a housed workflow and an unhoused workflow. We want to have a BMC hospital at home workflow. So we are looking to see that there's an area that we can give the meds, but also we're not going to be naive. We also want to be mindful, especially as it relates to controlled substances, that we should not have open, free access to other persons in that setting to access the medications. So we went around to 2 sites, actually, maybe in the last 2 to 3 weeks, and looked through. And I would say yellow flag would be where there were like 4 to 6 patients in one room. We thought, that would not be ideal. That doesn't allow enough privacy, even though there's a curtain, because there would be, outward speaking about the patient's care. We identified another site where there is more privacy. There's a room, and this room actually had its own bathroom in that room. It's currently a 2-bed setup, but we're thinking through how we could maneuver that, whether to keep it as a 2-bed setup or whether it would need to be a 1-bed setup. We've thought through how we can have a lockbox for meds, including the possibility of utilizing the existing structure within the respite setting. Another thing to consider is within a respite, there are already services unique to the respite being delivered. Like they have their own nurses or nurse practitioners or PA. How can we integrate with the existing system so we're not, 1, duplicating effort, or 2, saying, this patient is crashing, look away because you're not hospital at home, right? So we're working through the logistics of how we can integrate with that respite system and work collaboratively rather than working as like separate. So I think this is still a work in progress, and we look forward to reporting on it if we are successfully able to integrate.
I love that perspective, and maybe that's a perfect time to transition to more of a discussion around privacy. And Rachel, I'd love to bring this question to you, in part because there's such a richness of variety of alternative living arrangements that your program has been going into. Can you talk more about how you thought about privacy and structuring privacy for patients in different settings?
Sure. So we do try hard to protect privacy in these group settings. Interestingly though, our veterans are typically comfortable around their peers and usually are more reserved about sharing information with their family than their peer veterans. That being said, the patients are typically sharing a bedroom with a roommate, sometimes more than one. We've been places where, you know, there have been up to 6 people in a room. But the roommates are typically respectful. They'll allow privacy. They'll leave the room. But on the chance that they don't, we can use other rooms in the house, go to the kitchen, living room. Sometimes we've even done visits outside if the weather permits. We just kind of take it where we need to.
For sure, very helpful. And I wonder too if you could react to the point that Fitz had shared, where they're operating in multiple different environments and also trying to have a single workflow for a single experience in a single home hospital. Can you talk more about this tension between customization for the different settings you folks are operating in versus the standardization, which can maybe be, looks good perhaps on a PowerPoint and something we all strive to, but at times we have to be flexible as we customize to these different environments?
Yeah, I would say we probably don't have one standardized workflow. We pretty much meet the patient where they're at and adapt from there. Of course, we try to maintain policy and procedure, infection control practices, all those things. But we do have to adapt even outside these group settings in patients' home that are, not the best environment. Yeah.
Couldn't agree more. And when we launched our program, we took essentially every medical center policy with a fresh set of eyes and adapted it to the unique environments in the home. And we could talk about infection control and privacy for probably hours, to say the least. And they're important topics for sure. So thank you, Rachel.
Yeah.
Maybe Michael, maybe let me turn to you. This is a med management oriented discussion,
Yes.
Which is a very important one. Can you talk a little bit more about what is different, or maybe more simple in thinking about med management in assisted living facilities?
Yes, we actually have a couple different ones here. Some, especially memory cares, have a policy for good reason that their staff passes the meds. And so we do have at the big facility we work with, we have for memory care. We bring the meds to them and they pass them, and we're still watching on the tablet and charting exactly what's being passed, but it is their staff passing them. At another assisted living, though, it's the same as our other patients. We bring them out and we organize them, and then they video in and they take them themselves. So there's certainly times where we adopt their policies, and there's kind of other times where we use our standard policies.
For sure. I think it's a good point around, if you've seen one assisted living facility, you've seen one assisted living facility.
Yes, that's very accurate.
And the creativity around how you partner with wellness nurses in those facilities. And we have found something very similar to you, which is there are unique characteristics in some assisted living facilities where we've received hard no's at times, which is challenging when we feel like we can care for the patient. And so that relationship building that you shared was so important. Let me pause there, and I'd like to open it up. I know we've got about 20 minutes or so, and would love to open it up to the broader audience. I believe John had shared, please put any questions in the Q&A, and we will. So one first question, which I think dovetails very nicely. So what type of med planner systems are in use when you manage medications? So we heard Michael talk a little bit more about their med approach being customized based on the assisted living facility. Fitz, Rachel, would love to hear from you.
Sure. So for our meds, we are utilizing the 5 rights of medication administration. We're partnered with Medically Home, where our nurses or physicians are remote, and our in-home clinicians, paramedics, and nurses are provided by our third-party vendor. So when the in-home paramedic or nurse goes in, they are reading the medications, and we're verifying through the 5 rights, right name, right route, right patient, right dose, etc. And that's how we're verifying the med administration for our patients. And that would be the same in the transitional and women and shelter setting. So the medication
Fantastic.
is in a like a med box that is by the patient's bedside, and we're now doing controlled substances in a lockbox.
Fantastic. Rachel, curious on your approach.
Yep. So for us, we set up medication plan, like a 7-day pill box. The patients typically self-administer all of their pills, all their routine standing meds. We do dose adjustments over the phone where the provider will call them and, give them instructions to, change or titrate medications. As far as any IV medications, the nurse is coming into the house and administering those.
I love it. And I think that the variety of approaches, a lot of creativity and thoughtfulness, I think for the technology aficionados out there, a call to action. We need a really interesting, cost-effective in-home med management technology that docks into our pharmacy system. So please work with us so that all 4 of us can use your technology in the future. I love it. All right, next question. So I'm going to go to, so there are a couple questions here that are directed to individual folks. So let's go, Dr. Nassif, and then I'll come to you, Fitz, for a question about BMCs. So Dr. Nassif, do you find the SNF and hospital operators see hospital home as revenue destruction, since the hospital gets paid for each admission and SNF gets paid more for return admission? I wonder, if you're also reducing the need for patients to require a skilled nursing facility, that might be good for the patient, maybe bad for the SNF. But Michael, to you.
I can tell you this, having a very good pharmacist friend who's now in the Southwest at a very large organization that runs multiple SNFs, they do see hospital and home as a threat, like on their literal corporate leadership, like what threats are out there, which is a good thing. I mean, my God, this is a good thing that, and we actually looked at our hospital in your home, like apples to apples, the exact same patients we admitted to hospital in your home in their younger life. 1 in 10 of them went to a sniffer rehab, and in hospital in your home, it drops 10x. So it goes to 1%. So I mean, I do think they see us in, but like I said, this is where the independent livings have no problem because the patient generally owns it. But assisted livings really should be, I think, motivated because they don't want turnover in their assisted living patients, and they don't want them going to a rehab, especially that's not affiliated with them. So, and we I think the VA potentially, or some of these entities that are payers could do SNF, but we can't do any SNFs just because that is a billing issue since we're billing Medicare A and the SNF is billing Medicare B.
Got it. So perhaps what you're saying is we should all take a little credit and kudos for being on the threat board of the National Skilled Nursing Facility, that it means we're taking great care of patients. So kudos, Rachel, Fitz, and Michael.
Yep.
Maybe let me come, I think the question just moved in front of me, so sorry. So Fitz, let me come to you for this next one. Just a question about how do you manage food delivery, food enrollment, a very tactical supply chain oriented question in different environments. And Rachel, then we'll come to you.
Sure. So we are doing medical meals that's delivered to the patient's home. I think we're currently using Mom's Meals, but it's similar to like a Meals on Wheels. We're also looking into, we recently had a talk with Cook Unity, but essentially we are medically tailored meals that's delivered to the patient's home based on the comorbidities that they have. And it's opt-in. So it's offered up front when we're screening the patients to ask if they need assistance with meals. And if they say yes, then we're able to provide it. They may also say they can do their own meals, they just need assistance with grocery, in which case we can assist with grocery through Instacart.
Very neat. And I think it gets back to the optionality and the flexibility of how do we meet this patient where they are versus we're bringing you an omelet every morning, which, kudos to our hospital teams, but, sometimes a little bit more flexibility is probably beneficial. Rachel, how are you folks managing food in the different environments?
Yes, so we don't provide any meal delivery service, but food insecurity is something that's assessed when we admit a patient. And our social worker will work closely with the patient to get them, Meals on Wheels or other food delivery, help them get shopping, go get groceries. We've had situations where the nurses go to the store and, get them something if they've been in the hospital for 2 or 3 weeks and they came home to an empty house. So we do make sure that they have food, but it's not coming from the facility.
Got it. Super helpful. I want to change gears a little bit. Darlene, I see you asked a question. Do you look at the security of your team going into some of these locations? Maybe talk more about how you thought about staff safety and comfort, and focusing also on health equity and how we think about our more vulnerable communities in terms of staff safety. So Michael, let me go to you, and then we'll come down to Fitz and Rachel.
Yeah, ironically, when we launched in July 2022, we had a contract with a security company who would kind of escort and go out with. There's some rough neighborhoods not too far from a couple of hospitals in Kansas City. We never used it one time, and I begged and pled with our guys, like, I just want to see if it works. Like, let's just go ahead. And we never use it. So we actually did not renew their contract this past year. We haven't had any occasion. We've had some times where we said, hey, if someone has to go out there after, dark to use the security, but it's never come up. So that's been our, unfortunately, no experience to date. We've had no issues. The worst we've had is one poor nurse practitioner got bit by a dog one time, which was bad enough, but that's been it. And we're going to have our 2000th admissions. Not to trivialize that, but thankfully it's only been one very minor incident out of 2,000 patients.
For sure. That's great to hear, and also great that you did not renew. Not feel like you needed to renew that contract. Fitz, to you.
Sure. I think that's a good question. So we are in Boston, and I would say that the areas that we serve tend to be the same at-risk areas that may be more renowned for being high crime areas. But like Michael, we actually have not had any security-related events to our staff to date. I would say we have had instances where the staff may have felt uncomfortable. So we do have the option to provide security to escort with a paramedic or nurse into the home. We are mindful of that because I would also say that in these at-risk patients, in these seemingly crime-ridden areas, we would also want to consider the fact that the security that may be coming with your clinician, with the nurse, may actually be seen more as a risk to the patient than, essentially, let me say it differently. In these communities, it is possible that the security coming may be viewed with, like, why is this person coming into my home? I have not done anything wrong, especially in the current climate. So we're definitely attuned to that, respectful to that. And then we also say, if that is the case, we first pass it by the patient to say, we are having, let's say, someone come to do a procedure, to do a midline, to do a PICC line, etc. They may be coming with assistance just as a routine part of their care. We will ask that they stop at the door.
Yes.
So we have utilized,
sure.
But we've never had an incident.
Very helpful. Thank you, Fitz. Rachel, thoughts from you?
We don't have any security team or anything like that, and we also aren't staffed well enough to do routine tandem visits if it's like a bad area or an unsafe home. So we do take that very seriously when the staff feel uncomfortable going in somewhere. We have had to discharge some patients due to the environment. We do have many veterans who have weapons in the home. It's very common that they do. We ask that they be locked up and secured, but we're also dealing with, cognitively impaired patients. So it has happened on a few occasions where, the weapons are out on the couch, what have you. So our social worker gets involved and meets with families and things like that to help make it a safe environment. Yeah, they also get we all do annual trainings on safety and prevention of disruptive behavior and things like that.
For sure. Stepping back for the moment, it's really interesting. We've cared for about 3,700 patients. I would say, just like the three of you, we have never had a staff member, one of our ED nurses in the home or MIH paramedics in the home, ever injured by a patient or family member. We've had one cat bite. So it's perhaps the aggressive cat, Michael, like your aggressive dog. And I think it is possible to over-index, I think, on the security concerns And we have built some protocols and procedures, Fitz, like the ones you described, to make sure that the trust flows both ways from our team. The other thing I think is a really interesting point is around, many of our nurses, for instance, in the home come from emergency medicine backgrounds where they spent decades seeing the social determinants driving so many of their patients' poor outcomes. And so I do think that there's a real emphasis on laser focus on health equity and just being robust to all sorts of environments, and just believing that by being there and understanding the social determinants, they can inflect those social determinants. But so kudos to all three of you for being laser focused on this issue. Maybe the last question for the four of us or three of us is actually a broader one that I really like. And this is from Jeff Teed, who says, more a comment. I would think reach ACOs under global capitation would want this in every market where they are taking risk. So maybe the question for this team, stepping back, going into alternative living arrangements allows you a better lens into the patient's lives and their lived reality. Can you talk more about how you're thinking about home hospital and a broader care continuum for your vulnerable patients? Are you deeply integrated in a broader care continuum? Are you early in that journey? Talk more about how this work in alternative living arrangements is docking into other health system care continuum work. So Michael, let me start with you.
Yeah, I do think that's like our biggest missed opportunity, is that we're in the home for 4 or 5 days, and then for the most part we're then out. One of our most successful things is we had a small Humana MA pilot where we were actually in the home for a 30-day bundle, and it was tremendously successful. And only because of some Humana MA financial troubles elsewhere was the pilot not renewed or expanded. And then the one we've started doing is we have an incredible geriatrician, Jill Houded. And so for some of our geriatrics patients, we leave the tablet out there, and she at least does a day 7 and a day 30 follow-up, just to make sure they're getting their meds, getting their therapy. And that's been tremendously successful. But I think it's one of the biggest opportunities we're missing in just in a fee-based one DRG environments, where I'm very jealous of the VA and some places that have hospitals and payers that are a little more longitudinally aligned. I do think that's the real value, is even a 90-day care continuum.
For sure. Would love to go deeper on the 30-day model and learnings that came out of that. Fitz, tell us more about how your system and you folks in the program are thinking about care continuum and alternative living arrangements and docking into services that exist within BMC.
Oh, yeah. So we have actually been doing that. I would say the most recent example was maybe just yesterday or the day before, where with the recent heat wave, there was, and I forget the name of the program, that BMC had partnered with to deliver like ACs and fans to patients. And we were able to tap into that. And for a patient whose house was quite hot, also being uncomfortable to care providers going into the home and home health aide being in the home, we were able to deliver an AC to that patient through that program that was already built in at BMC. And similar exists for other social determinants of health that we have identified, from concerns with, rising bills. We have a program for that, and like the electricity power share program that we have. So we are leveraging all that BMC is offering to patients in general and translating that to our hospital at home patients, including like we have a meds to bed in brick and mortar. We don't call it meds in hand, because for our patients who are being discharged from hospital at home, the meds are couriered to their home at discharge.
And think about, Fitz, that vulnerable patient with heart failure going home on a new higher dose of diuretics with a 100-degree temperature that perhaps the brick and mortar teams wouldn't have known about. And suddenly you're there in the home saying, we can address this. Kudos to you and your team, to say the least. Rachel, I think you're probably the perfect person to wrap this question. The VA has a long history and legacy of doing this work in an excellent fashion. Talk more about how home hospital docks into care continuum at the VA.
Yeah, I think that's probably where the VA thrives in this area, because we can focus on the whole patient and we're not being held to all of these rigid reimbursement regulations and things like that. We can really do what we want, what we think the patient needs. And we follow them for quite a long time. 4 to 6 weeks is the average. And so we really try to meet all of their needs, whether it's medical or social, and get them really tucked in, follow them through that transitional phase of coming home from the hospital, and really prevent that readmission, and just ultimately get them on the best trajectory forward. So yeah, that's probably what I love the most about this job. Yeah.
For sure. Kudos to you and your team. The VA has been in many ways trailblazers in this work for decades, and so we all have a lot to learn from you. Stepping back, I know we've just got a minute or two left. I think my favorite tongue-in-cheek quote, tongue-in-cheek quote was, "If you go to an alternative living arrangement, you too can be Taylor Swift." So I love that. So all of us can be Taylor Swift. If I had to summarize in 4 quick statements, I would say what you heard today from our incredible panelists are intentionality, creativity, getting to yes for all of our patients, and the most important point in my mind is it is very possible to provide excellent care in a social determinant-oriented fashion in a broad array of alternative living environments. And these panelists are really sort of showing us the way forward. So kudos and thank you to all. And again, a big shout out to our Hospital Home Users Group leadership, the Hospital Home Users Group, and for sure our panelists today. Thank you for sharing all of your wisdom with us. John, to you.
Thank you, Taki. Again, and thank you to all of our presenters here. Just a couple of reminders about the Hospital Home Users Group annual meeting on October 16th. You can learn more about that at the using the QR code or to register. And we do send out, we'll be sending out emails over the next several months to give you more information about that. And again, we look forward to seeing you there or with the American Academy of Home Care Medicine in New Orleans in the Big Easy. So hope you can join us either in person or online. Again, another reminder about the minimum data set initiative that we are working on in at Hospital at Home, the Hospital Home Users Group. And so we're asking folks to come and join us and to share your information with us, de-identified. We have 35 hospitals already actively collaborating on this. And again, there is a short, you can scan the QR code, fill out a short interest survey, and we'll come back to you and get you involved in this effort. Really looking forward to developing this registry that certainly will serve the field. Remember, there are so many webinars out there, as well as our Technical Assistance Center. You can find this webinar in the next week or so on the events page at hahusersgroup.org. Again, hahusersgroup.org is the website of our of the users group. Lots of great information there, including the Technical Assistance Center. There are all sorts of resources there. Our featured resource here is an introduction to age-friendly care in hospital at home. And again, we are developing unique and new resources, likely based on this webinar as well. And so again, we appreciate all of your contributions in developing that technical assistance. And if you are a member of the Hospital Home Users Group on Basecamp, our Basecamp community as well, feel free to ask questions and or to join our office hours, which happen approximately once a month. And last, of course, but not least, we want to thank our sponsors, the John A. Hartford Foundation, for the support of this webinar series and for the users group, as well as the American Academy of Home Care Medicine, which is our partner on our annual meeting and on so many efforts related to really high-quality home-based care. On behalf of Dr. Michaelides, excuse me, Dr. Fitz Shepard, Rachel Mears, and Michael Nassif, thank you all for your contributions this afternoon, and thank you all in the audience for your great questions and for your kind attention today.